Hi, everyone. Thanks for coming. My name's Sukhpreet. It's reverberating for some reason. Cool. My name is Sukhpreet. I'm the Associate Program Director for our Addiction Medicine Fellowship. Thanks for coming in. Is it echoing a little bit? We'll ignore that. I'm very happy today to introduce Stephen, who is one of our current Addiction Medicine Fellows, also a fifth-year GIM fellow. He comes to us from UT, where he did his core internal medicine training. He's got his fellow colleagues over there in the corner. Stephen's going to be talking about a very interesting topic using GLP-1 agonists in the treatment of alcohol use disorder specifically, a topic that I think is very topical, interesting. When he is done training with us, he hopes to take care of patients in inpatient settings and improve care there as a general internist and addiction medicine physician. So, Stephen, take it away.
Hello, testing. Okay, perfect. Thanks so much, everyone, for coming out here. I was just saying, I remember coming to these sessions for free food, and oftentimes I stuck by because the talks are very interesting. So hopefully you can take something away from these discussions. Thank you for the introduction, Sir Preet. So the title of my discussion today will be New Shots to Sobriety. We'll be exploring the role of GLP-1 receptor agonists for alcohol use disorder. Before I start, I want to acknowledge that I am presenting this talk here as a humble guest on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. And I have no disclosure to report. After this presentation, I hope that you can better understand the mechanism of GLP-1 receptor agonists and their role in the neurobiology of addiction. We will also be looking at the evidence, prescription considerations, and some future direction for the possible use of GLP-1 receptor agonists in the treatment of alcohol use disorder. Now, if someone asked me in this room, like, what is the #1 hottest drug out there? I think I would say that it is the GLP-1 receptor agonist without much hesitation. And I would assume that many of you in this room have encountered this class of medication via more common trade names like Ozempic or Wegovy. And in the last few years, there has been significant increase in the use of this medication. But alongside that, there's been growing public and media attention as well. For instance, like when I'm on Instagram or TikTok, I see a lot of influencers or celebrities talking how their lives have changed with Wegovy and Ozempics. And it certainly has emerged in the last 5 years or so as a really popular medication. And I'm not making this up. There are actual data and numbers to support how much this medication is being sought after. In 2023, data shows that approximately 7 million prescriptions were dispensed in Canadian pharmacies. And as a matter of fact, in 2024, Ozempic, or the brand name for semaglutide, one of the GLP-1 receptor agonists, it was reported as the third most dispensed drug in Canada. And compared to 2023, that number of prescription has actually increased by 17%. The actual number in 2024 for the prescription of Ozempic is not that far off from maybe more commonly encountered medication like vitamin D, which is second on the list. And also note that this is more prescribed than methadone, which is fourth on the list there. And this is not just a Canadian phenomenon. In the United States, there was over 700% increase over the last 4 years of GLP-1 receptor agonists in patients without diabetes. I'm not talking like 70%, 700%, and that's a lot. Beyond their utility as a wonder drug for weight loss, there has been increased use for other indications. Evidence from, we have respectable journals like the NEJM, JAMA, they have reported the utility of this class of medication in that they're able to decrease outcomes in heart failure, slow down renal disease progression, not only to mention that it helps with glycemic control in diabetic patients. And I think this medication has slowly gained the reputation, as I said, as a wonderful drug that can help to address various medical comorbidities. And from my experience on medicine, I've had few patients on CTU who've asked me about whether they can go on these medications. So what exactly is GLP-1 and GLP-1 receptor agonists? I think when we're talking about the possibility of this medication for alcohol use disorder, I think we have to know more than just recognizing Ozempic and Wegovy. So GLP-1 stands for glucagon-like peptide 1. It is essentially an amino acid peptide that is produced predominantly by your gut and to a lesser degree in your brain. in response to nutrition ingestion. It has a very short half-life, about 2 minutes, and is rapidly degraded by an enzyme that you might have heard before in your endocrinology class called DPP4. And then once it's secreted, it activates various receptors in your body to exert their effect. So essentially, GLP-1 receptor agonists are medications that mimic GLP-1 by activating the GLP-1 receptor. So when GLP-1 binds to the receptors, the effect of its outcome really depends on the location of GLP-1 receptors. In the pancreas, let's start off. GLP-1 causes insulin secretion. It also inhibits glucagon release, and this all contributes to the anti-glycemic effect in someone with diabetes. In the gut, GI motility is slowed down, resulting in delayed gastric emptying. This is why if you're on like a impact service, the surgeons love to hold this medication before their surgery prior to like anesthesia. Essentially, food stays in the stomach longer, you feel fuller sooner and longer, and it blunts that post-meal glucose spike. In the kidney, it causes increased sodium excretion and it causes mild diuresis. There's also a postulation that it reduces the intraglomerular pressure, protects against hyperfiltration, which may be common in conditions like diabetic kidney. And all of these mechanisms are thought to really slow down renal diseases. And in the brainstem, GLP-1 contributes to the autonomic regulation. This modulates vagal activity, affecting blood pressure, heart rate, and research suggests that this may in turn lead to cardiac function regulation. And this is maybe why in someone like with heart failure or cardiac diseases, there are some benefits. And I think most relevant for us in the field of addiction medicine, GLP-1 system is also involved in the mesolimbic system, where it controls the rewarding effect. So let's talk more about GLP-1 system in the CNS. These receptors are expressed in various parts of the CNS system, including in the areas implicated with reward and addiction. Notably, the expression have been identified in brainstem, thalamus, nucleus accumbens, amygdala, and hippocampus. And to go into this even further, this is a cross-section of the brain. I hope you paid attention in your biology and anatomy class, because I certainly haven't, and this was a review for me. But in the brainstem, shown at the bottom in the turquoise color, we have already identified that GLP-1 modulates autonomic regulation. We can also appreciate the structures of the mesolimbic system in the yellow, which has a central role in reward, as I said, motivation, reinforcing, learning, and addiction. And in the mesolimbic system, the dopaminergic neurons in the ventral tegmental area in the midbrain is projected into the limbic structures, especially the nucleus accumbens, but also to the amygdala, hippocampus, as well as the parts of the prefrontal cortex. And I've identified these structures in red boxes for your reference. And studies have shown that GLP-1 receptor activation in the ventral tegmental area can modulate dopaminergic activity. It influences reward-related behaviors. For instance, activation in the VTA has been associated with reduced intake of palatable foods and attenuated response to addictive substances. Going beyond the ventral tegmental area, the activation of GLP-1 receptors in the nucleus accumbens has been linked to decreased motivation for rewarding stimuli, suggesting once again a role in modulating reward-seeking behaviors. In the amygdala, activation is thought to regulate the emotional aspects of reward processing, stress-related behaviors. And finally, in the hippocampus, where learning and memory takes place, activation has been thought to render neuroprotective effects and modulate cognitive functions, and this may all be indirectly affecting reward-related behaviors. Now, of course, this is just a rough idea of how our brain works. Further research is necessary to elucidate the exact mechanism, but this gives us an idea how GLP-1 system can exert its effect in addictive behaviors and rewarding processes. Okay, so that was a lot of information. Let's just quickly recap. So first of all, we've identified that GLP-1 receptor agonists are used for various conditions, heart failure, renal failure, etc. The effect of GLP-1 receptor agonists truly depends on the location of receptors in your body. And we have also seen some evidence that GLP-1 system can modulate craving and addiction. Okay, so we so far have talked about what GLP-1 system is, some of its common indications, the neurobiology of addiction, and how GLP-1 agonists are implicated. Let's briefly talk about some existing GLP-1 receptor agonists. The following list here are medications that are FDA approved, and one with the Canadian flag is also Health Canada approved. Commonly encountered medications like Ozempic, Wegovy are brand names for semaglutide. But there are certainly a lot of options out there. Now, GLP-1 agonists like Wegovy, Ozempic are weekly injections, but there are also other forms of GLP-1 receptor agonists that are slightly different. For instance, we have a medication called Rybelsus, which is a daily oral GLP-1 receptor agonist. Oral semaglutide, like this medication, has a very slow absorption. So the achieved plasma concentration is thought to be lower and more variable than a subcutaneous injection. So that's why to maintain therapeutic level, you have to take this medication every day instead of taking it once weekly. Okay, so I think we talked enough about GLP-1 receptor agonists. Let's shift the gear to talk more about alcohol use disorder. Most of you here are on addiction medicine, psychiatry medicine, emergency background, and I don't have to emphasize that alcohol use disorder is very common in Canada. We have estimated 1 out of 5 individuals meeting criteria for this disorder in their lifetime. And globally, it is not surprising that alcohol use contributes to 5% of the global burden of disease. Here in Canada, you might have encountered in the BCCUSU guideline, we typically determine if someone has alcohol use disorder by applying the DSM-5 criteria as shown in the right side. The criteria essentially includes components of cravings, withdrawals, use in dangerous situations, all the other negative consequences. And to really meet the diagnosis, you need to have at least 2, and the severity of your disorder depends on how many of these items that you qualify. Now, in our previous slides, we discussed briefly the mesolimbic system. So I think this is a nice segue to briefly touch upon the neurobiology of alcohol use disorder. When one drinks alcohol, let's say they go to a bar, they take a shot of tequila, it releases endorphins, and that activates the opioid mu receptors in the ventral tegmental area. And the activation of the opioid receptors is thought to disinhibit dopamine neurons by acting on GABAergic interneurons in the ventral tegmental area. And this essentially causes more dopamine to be released, causing a dopamine flood into the nucleus accumbens, creating this reward reinforcing feelings. There's also some contribution through the NMDA system, NMDA inhibition that reduces glutamate drive into the inhibitory neurons, and this further contributes to the dopamine neuron firing. In Canada, we have 2 first-line pharmacotherapy for alcohol use disorder, naltrexone, acamprosate. Just briefly, naltrexone, it works by acting as an opioid receptor antagonist. And based on the neurobiology of alcohol use disorder, as I just mentioned, you can imagine how this will effectively stop the dopaminergic flood into the mesolimbic system, reducing the pleasurable effect of alcohol. Acamprosate works slightly differently, but essentially modulates the glutaminergic neurotransmission. It acts on the NMDA and GABA system. And of course, we have these other alternative medications out there that you might have heard, ondansetron, gabapentin, baclofen, and et cetera, as listed above. There are reports in the literature that GLP-1 is very closely linked to alcohol use disorder. Genetic studies have shown that the mRNA responsible for the expression of GLP-1 receptors were elevated more in the hippocampus of those individuals suffering from alcohol use disorder versus healthy controls. This was actually confirmed when they did a post-mortem study of individuals with alcohol use disorder. They found more receptors expressed in the hippocampus as well as the prefrontal cortex. And there is also an association that they found between polymorphism, which essentially means different forms or variants of the GLP-1 receptor gene, and the AUD score test. I'll talk about the AUD score later, but essentially that score is a standard questionnaire that measures alcohol use and risk of alcohol problems. There's also data from preclinical studies that liraglutide, which is one of the GLP-1 receptor agonists, decreases alcohol-induced dopamine release in the mesolimbic structures that we talked about. And semaglutide has also shown to reduce alcohol consumption in rodents, via a mechanism thought to relate to alteration in the central GABA neurotransmission. So preclinical studies up to date have shown various benefit of GLP-1 agonists in decreasing consumption of alcohol, reducing motivation to consume, leading to more abstinence symptoms in rodent studies. Let's now shift the gear and talk more about the clinical studies involving human participants. I will share the most relevant studies in the last 3 years in chronological order from the oldest to the most recent. This is a study by Clausen et al., exenatide once weekly for alcohol use disorder. This was a double-blinded, placebo-controlled RCT published in September 2022. In this study, they've included treatment-seeking patients with alcohol use disorder who were assigned to receive exenatide, again, which is one of the GLP-1 receptor agonists, 2 milligrams subcutaneously versus placebo weekly for 26 weeks, in addition to the standard cognitive behavioral therapy, which both groups received. Interestingly, they used the DSM-5 criteria to include patients with AUD, and I mentioned that this is important because not all studies use the same criteria to identify patients with AUD, as we'll discuss in a bit. And the primary outcome in the study was the reduction in the heavy drinking days. And they also looked at some secondary outcomes using some functional imaging, such as MRI, as well as a single photon emission CT or the SPECT brain scans. And in terms of the result, they found that exenatide did not reduce overall alcohol consumption, but when they did a subgroup analysis, they revealed that individuals with obesity with BMI greater than 30, this GLP-1 receptor agonist medication did reduce heavy drinking days by about 24% points and reduced the total alcohol intake per 30 days by about 1,200 grams. This is all relative to placebo, of course. In their secondary outcome, they also found that this exenatide medication, they attenuated fMRI alcohol Q reactivity in the ventral striatum and the septal area, which are crucial brain areas for, again, drug reward and addiction. And the SPECT scan showed that dopamine transporter availability was much lower in the exenatide group compared with the placebo. Interestingly, I should mention that this group excluded patients with severe mental disorder, other substance use disorders as well. And I think we should also keep in mind that given how closely psychiatric conditions are linked to alcohol use, the result of this study may not be truly applicable for the patients that we often see in our clinical setting. We also see patients dependent on alcohol with other concurrent substance use disorders. So we should keep that in mind as we interpret studies like this. Another study was published in November 2023. Moving forward, this was by Probst et al. These authors initially conducted an RCT placebo-controlled trial evaluating the use of GLP-1 receptor agonist dulaglutide and whether this increased abstinence rates from nicotine during smoking cessation. And this study was a secondary analysis of that initial study, and this was a double-blind randomized secondary analysis of that initial double-blinded randomized placebo-controlled trial. The main objective of this secondary analysis was to assess differences in alcohol consumption after 12 weeks of treatment with dulaglutide compared to placebo in conjunction with the standard counseling sessions. Now, a limitation of this study is that patients who reported alcohol use did not have alcohol use disorder per se based on the DSM-5 criteria. Keep in mind that this was a secondary analysis of an original study that included patients with moderate to severe smoking dependence, but this was not initially focused on alcohol use disorder. And just to give you more information, in both groups, the median alcohol consumption at baseline was 3 standard glasses per week, and 12%, about 18 patients, classified themselves as heavy drinkers, classified by patients who were female who drank more than 7 drinks and male patients who drank more than 14 glasses of alcohol per week. What the study showed, nevertheless, despite that limitation, was that at 12-week, participants in the dulaglutide group drank an estimated 30% less alcohol, and this was an effect independent of smoking status based on alcohol consumption or body weight compared to placebo. And there was no interaction between baseline alcohol consumption and treatment, meaning that the effect of dulaglutide on alcohol consumption at 12-week did not depend on the baseline alcohol use. In that same year, there was a retrospective review that was published, including patients treated with semaglutide for weight loss, who also had positive screening for alcohol use disorder. Now, the way they included alcohol use disorder is that they've used the AUD score. Anyone with an AUD score greater than 8 was included prior to initiation of semaglutide for weight loss. The outcome of intent was reduction in the AUD score. Okay, so I think I talked about the AUD score enough, and I think that of itself deserves attention. The score refers to the alcohol use disorder identification test. This is a questionnaire that was developed by the WHO to assess alcohol consumption as well as drinking behaviors and alcohol-related problems. This test has 10 questions, each scored from 0 to 4. It gives you a maximum score of 40 points. Score between 0 to 7 is thought to be low risk. 8 to 15 hazardous drinking, 16 to 19 harmful drinkings, and anything greater or equal to 20 thought to represent alcohol dependence. So as I mentioned, this study included patients with the AUD score greater than 8. So 6 patients were identified in the results. They used a statistical analysis to compare the initial AUD score as well as the AUD scores after initiation of semaglutide therapy. And 6 out of 6, 100% of patients had significant reduction in the alcohol use disorder symptomatology based on the AUD score improvement following treatment with the GLP-1 receptor agonist, with the mean decrease of that point by about 9.5 points. Now, obviously, the limitation of this study is that this is a very small sample size of a retrospective study of 6 patients. This is not a controlled design like an RCT. And I think it's too far to draw robust conclusion from this study alone. There's no control of comparison groups, and there's no control of confounders. So we should just keep that in mind as we interpret this as well. The next study is one published in JAMA Psychiatry in November 2024. This cohort study was an observational study conducted nationwide in Sweden using data from 2006 to 2023. So this was a few decade follow-up. The main exposure was patients who were exposed to GLP-1 agonists, which were exenatide, liraglutide, dulaglutide, and semaglutide. And they also looked at secondary exposure, which was other alcohol use disorder medications like disulfiram, acamprosate, naltrexone. The primary outcome that they looked at was hospitalization to alcohol use disorder. And the secondary outcome that they also looked at was somatic hospitalization, suicide attempts. Now, in this study, they use a within individual design where each individual acts as their own control. In other words, for each person, you look at the on-drug time and off-drug time, and you see whether the rate of hospitalization is different in those periods. In terms of the risk of hospitalization for alcohol use disorder in GLP-1 exposed individuals, semaglutide and liraglutide were associated with decreased risk of hospitalizations. Semaglutide had the lowest risk with the adjusted hazard ratio of 0.64, and the use of liraglutide was the second lowest risk with the adjusted hazard ratio of 0.72. And they also mentioned that use of any alcohol use disorder medication, the 3 that I mentioned, the disulfiram, acamprosate, naltrexone, it was associated with moderately decreased risk as well. And I was interested to see how they define hospitalization due to alcohol use disorder, because when you're working in emerge or medicine, you often see patients coming in with nausea, vomiting. They may be in withdrawal. They may be intoxicated. They may have other sequelae of alcohol use. They unfortunately did not mention that. They simply said, we identify patients who had an ICD code of alcohol use disorder on their admission. So that part is a little vague. Moving on to the secondary outcomes. So semaglutide and liraglutide use were also associated with decreased risk of somatic hospitalization. And I think we should also be mindful of the limitation of the study in that, they try to use each individual as their own control, but this is once again not like a true randomized control study. And there is a time varying confounders when you use a design like this, where there are confounders that change over time. So worsening health, onset of diseases, and other changes in medication, as well as your behaviors change over time, right? So even if you use yourself as a control, there are other factors that would not be accounted if you use such intervention. I should also mention that they looked at the risk of suicide, and I'll touch upon this later on. Lastly, here's a more recent study. This is a double-blinded RCT in the United States. They only had 48 patients who were included. They included patients with alcohol use disorder based on the DSM-5 criteria. Patients received either semaglutide versus placebo, and their primary outcome was laboratory alcohol self-administration, measured pre-treatment and post-treatment, and they also looked at change in alcohol consumption and cravings overall. The patients here in the study were non-treatment seeking, meaning that participants were not actively seeking or enrolled in treatment for their alcohol use. So that is a subtle difference from the other studies who included patients who were actively seeking treatment. And what they shown was that semaglutide significantly reduced the amount of alcohol consumption in laboratory self-administration. Testing after treatment, as shown in the graph above, there was also reduction in the alcohol consumed in grams, as well as the peak breath concentration in grams per deciliter. The secondary outcome change in alcohol consumption and cravings, I should mention. Now, semaglutide did not affect the average drinks per calendar year or the number of drinking days. It did significantly reduce drinks per drinking day, as well as weekly alcohol craving. And there was also evidence of reduction in heavy drinking over time. I put the star in the ones that have reduction. Apart from the studies that I shared, there are also other ongoing clinical trials that are looking at GLP-1 receptor agonists and alcohol use disorder. The list includes clinical trials, mostly that are ongoing. And as you can see, semaglutide seems to be a very popular drug of choice for GLP-1. And if you look at the inclusion criteria, there is heterogeneity, much like the studies published that I've shared with you. And some are looking at alcohol use disorder patients based on the AUD score. Some are using the DSM-5 criteria. Others are using the amount of alcohol intake per day/week. So there is some variation, but stay tuned for the result of these studies. Okay, so to summarize, we have seen some evidence in preclinical studies that GLP-1 receptor agonists can reduce alcohol consumption and addictive behaviors in rodents and animal studies. And we have also glanced over some emerging new clinical trials with some limitations demonstrating the potential use of these medications in patients with alcohol use disorder. I think we should also discuss some of the possible side effects of this medication. As a matter of fact, in the studies that I previously mentioned, the most common side effect were GI symptoms, including nausea, vomiting, diarrhea. In the Clausen et al. Study, for instance, there was almost double rate of adverse GI events in those taking GLP-1 receptor agonists. And in the other study that we looked at, there was even a higher incidence of GI symptoms in the GLP-1 receptor versus placebo. And this kind of raises the question, were we appreciating the decrease in alcohol consumption because the medication provided as a negative reinforcer? If people are having nausea, vomiting, diarrhea, I don't think they would necessarily want to go and drink alcohol. So that's something to keep in mind. So GI symptoms are really the most common side effects associated with GLP-1 receptor agonists. I think other adverse effects that we should recognize, there is a risk of pancreatitis, especially in those individuals with a history of pancreatitis. One should be cautious. And again, when we're talking about alcohol use disorder, how many times have you seen alcohol-related pancreatitis? So I think prescription consideration needs to be carefully weighed in here when your patients often come here with the sequelae of alcohol use, and that may be pancreatitis. Other side effects include AKI from all the GI side effects, retinopathy due to rapid A1C reduction, gallbladder disease, and there is actually a black box warning of medullary thyroid cancer. This seems to be based on some rodent studies, but the use is typically contraindicated if you have a personal or family history of thyroid cancer. Another adverse effect that I should mention that was recently spotted in the media is the possibility of increasing the risk of suicidality. After semaglutide, including Ozempic, Wegovy, as well as liraglutide, became more readily available for weight loss, regulators have started to receive spontaneous reports of mood changes, suicidal ideation, and rare suicide attempts. And there were individual case reports, not from clinical trials, that were enough to raise a pharmacovigilance signal. And it is speculated that since GLP-1 receptors are expressed in the brain, including mood-regulating regions like the thalamus, ventral tegmental area, amygdala, et cetera, there might be indirect modulation of, serotonin, stress hormones, or the changes in eating behaviors, body image, which can all affect mood. All that to say, these reports have triggered investigation from both the FDA as well as Health Canada. In early 2024, the United States FDA launched its own review after receiving similar reports through its FDA Adverse Event Reporting System database. And their most recent update as of January 2024 indicates that the preliminary evaluation, they didn't find evidence that GLP-1 receptor agonists cause suicidal ideation or behavior, but obviously they suggested ongoing monitoring because they couldn't rule out the small risk. In Canada here, around December 2024, Health Canada also launched their own investigation, a safety review, and the result of their review concluded that there was no causal link between GLP-1 receptor agonists and increased suicide risk. Now, I wanted to go into this a little bit further because it's great that these agencies have done the hard work for us, but I want to see what some data suggests that this is safe in individuals when it comes to not affecting suicide risk. One of the study in the JAMA Internal Medicine from Wadden et al., they did publish the psychiatric safety study of GLP-1 receptor agonist semaglutide, and they in particular looked at whether high dose of this medication for weight loss increases risk of depression, suicidal ideation, or suicidal behavior in people without known major psychiatric comorbidities. And this was a post hoc analysis of previously conducted clinical trials. I should note that patients with existing psychiatric conditions like major depressive disorder, et cetera, or history of suicidal attempt were excluded. And what they measured was depressive symptoms as well as suicidal ideation behavior using different questionnaire and scales. And they found that the 2.4 milligram of semaglutide did not increase the risk of developing depressive symptoms or suicidal ideation compared to placebo. And obviously, a huge limitation in this post hoc analysis is that they've essentially excluded patients with serious psychiatric illnesses, a history of suicidal ideation. So the result, again, may not be applicable in those patients who have existing psychiatric conditions. As we have already said, we know that many patients with substance use also struggle and suffer from psychiatric comorbidities. I want to go back to the study that I shared before, the one that was published in JAMA. As I said, one of the secondary outcomes was suicidal ideation, and I thought it was more appropriate to talk about this now as we're evaluating the suicidal ideation and the risk of self-harm. Just to give you a recap, the main exposure in the study was GLP-1 agonist receptors, and the secondary outcome was suicide risk. And they did not find a statistical significance when it comes to the association between semaglutide or liraglutide and suicidal attempts in the studied cohort. For semaglutide, for instance, the adjusted hazard ratio for suicide attempt was 0.55. And liraglutide had a hazard ratio of 1.08, which was not statistically significant. Interestingly, the use of other alcohol use disorder medications like acamprosate, naltrexone, et cetera, that was associated with increase of suicidal attempt. So overall, while there are reports of concerns for increased suicidal risk, we don't have strong evidence, it seems like, that there is actual increase in risk based on the study that we have evaluated thus far. Okay, so GLP-1 receptor seems promising, but is it really affordable? Based on the quote by Uncle Ben from Spider-Man, with great medications or powerful medication, there's always a cost involved. And sometimes it's hard for us when we're ordering things on Cerner. We have to keep in mind our patient's financial status. So I want to share this data from the BC Ministry of Health that lists approximate annual costs associated with some of the more common GLP-1 receptor agonists used for weight loss. And the annual cost ranges from $5,000 to $10K per year. If you do the math and divide that by the number of months, that's about $400 and $800 per month. And drawing from my experience, caring for patients with substance use, I'm not sure if this number is really realistic. Many of our patients who struggle with addiction are marginalized. They are often on welfare disability leave, and this makes access to these medications a significant concern. I also wanted to mention, interestingly, Novo Nordisk, which is one of the makers of this GLP-1 receptor agonist, they will lose their market exclusivity on this drug in Canada starting in January 2026, because I think they failed to pay a fee that gave them that right. And what this may lead to is potential affordable generic options. But until then, cost seems like a huge, huge barrier. So to summarize, we have promising but rather early evidence. We have preclinical models and early human studies suggesting GLP-1 receptor agonists playing a role in reducing alcohol cravings, intake, and relapse risk. There is certainly a need for a more robust study. We have seen some RCTs trickling, but we need a larger study before we can really determine whether this is acceptable for clinical adaptation. There are also practical concerns, right? Cost, insurance is huge. As I talked about, this presents a significant barriers for our patients. And the adverse effects of GI intolerance, it should really be weighed carefully in our patients who may also be having a lot of GI upsets from alcohol use disorder of itself. And in terms of future direction, I mean, it certainly has the potential to become an adjunct to existing pharmacotherapy if efficacy and safety are concerned. And safety are confirmed, but more work needs to be done. So I think overall, it's a promising agent, but it's still rather experimental. I also want to share some other possible areas of future direction for GLP-1 receptor agonists in the management of alcohol use disorder. First of all, not all GLP-1 receptors are equal. There is variation in half-life. There is potential variation in this ability to cross a blood-brain barrier. And I think this needs to be better characterized in future studies. A lot of studies have looked at like semaglutide, but I'm curious to see what other molecules act. There have also been human studies that identify several polymorphism in the GLP-1 receptor gene that may influence response to these medications. So I think these insight really underscores the importance of integrating genetic profiling into future clinical trials if that's feasible. And there is also reported differences in metabolic phenotype that may significantly influence treatment group. Studies, including the ones that we have looked at in subgroup analyses, they found improvement in alcohol use in patients with obesity. And there may be variation in metabolic profiles that may be associated with differences in gut-brain signaling or differential receptor expression. And I think future studies, it will be helpful to see if the efficacy of this medication can be stratified across multiple metabolic subgroups. Now, just out of interest, because we not only treat alcohol use disorder, we treat opioid use disorder, cannabis, et cetera. I came across some other studies. There are a lot of preclinical animal studies that show the positive outcome in this medication, improving craving and addiction, and all of the aforementioned substances. Clinical trials are limited to observational studies, and there is an RCT ongoing for opioid use disorder that may be interesting to follow up in the future. And here are my references. Thank you so much. If you can just take a quick moment to fill out the survey, I would appreciate it. And I thank you for coming today. I think they're in a post-food coma at this point in time, so I understand.
What would you like to see happen or evaluated before you felt like this was a viable, even experimental or off-label?
I think just better delineation whether the reduced alcohol consumption is not necessarily from like the side effect that they're experiencing. As I said, nausea, vomiting, and gastroenterology, GI symptoms are the most prevalent side effect of this class of medication. And I think it will be helpful to really tease out the mechanism of how this is reducing their alcohol intake. Is this acting as a negative reinforcer, or are there actual positive changes in their brain that are appreciating? So I think more studies need to be done. I think also, because there's so many GLP-1 receptor agonists out there, I think it will be also helpful to kind of study each and one of them and see which one is more efficacious, but also one that can decrease side effects to the most possible. And I think the biggest one is cost and the access to this medication, which presents as a huge barrier. So if the triad of all that is fulfilled, I think I may be better convinced. But at this time, there are certainly enough barriers and considerations that, you know, I still need to be convinced by. Yeah.
Well, seeing any more questions?
Thank you very much.